everybody, and welcome to week 8. Sorry that this lecture has to be recorded, but as you know, I'm out of town this week. So I'm going to be going over all the information you need for today in 2 videos. This first video will talk about oxygenation, and the second video will talk about sterile technique. And those videos will be played for you today, and then you will practice the skills that you're going to be learning in each one of the videos. So the first thing we're going to be talking about is oxygenation. And you're going to find that a lot of your patients are going to, at some point, need to be put on oxygen. And one of the first things that always comes up is, do you need a doctor's order to put somebody on oxygen, okay? And the answer is yes, you do need a doctor's order to put somebody on oxygen, but does that mean that you let somebody struggle who's not breathing very well, whose O2 sat is really low, and not put them on oxygen first because you're waiting to go call the provider? And the answer is you do not wait to call the provider. You always treat the patient first. Remember your ABCs. So if you have a patient who's in respiratory distress and you need to either put them on oxygen or increase their oxygen, you're going to do that first. And then you're gonna, of course, either call a rapid response if the patient's really struggling, or you're gonna call the provider and let them know the changes that you've made, because obviously there's something causing that patient to need oxygen or to require more oxygen. So therefore you're going to need to escalate the situation to the provider and try and determine what the underlying cause is, okay? So when you do finally get the patient either on oxygen or get an order for oxygen or whatever the situation may be, you're going to typically see in the order set, the doc will write an order for the patient to be on oxygen, and that you have the ability to titrate the oxygen to maintain an O2 sat between, let's say, anywhere from 92% to 100%, right? Normal is 100%. We prefer our patients to be over 92%. If they start dipping below 92%, you know, that's troublesome for us, and we want to figure out why. We want to listen to the patient's lungs, check their respiratory rate, check their O2 sat, sit them up, and then try and figure out what the underlying cause is, but at the same time giving them the oxygen that they may need. How we deliver that oxygen is sometimes a little bit confusing. There's a lot of different ways that we can give a patient oxygen through a lot of different devices, and I'm going to go over each one of those devices and explain to you what the device is and how much oxygen you can give the patient, how high you have to turn the flow meter up on the wall, and what percentage of oxygen you're going to be giving the patient, okay? So just so you know that oxygen does get connected to the head wall. The head wall behind me is obviously a portable head wall. In the hospital, the head wall is built into the wall. All the gas lines run behind the wall in the hospital. So your compressed oxygen, your compressed air, those kind of gas lines are running in the wall. And we're basically tapping into those compressed lines through our oxygen flow meter. The oxygen flow meter, right, is always green in color. And basically you're going to be plugging that flow meter into the head wall where it's green or marked oxygen. And you're going to feel pressure when you're trying to connect the flow meter into the head wall, because remember, the oxygen behind it is under compression. So there's a little force to get the actual flow meter into the wall itself. Typically you see them already in the wall, but sometimes they're not, and you have to run and get one. These are what we call kind of quick connect connections. So you're kind of pushing in and then screwing it tight onto the wall. The flow meter itself has a little dial, and again, you're going to turn it to open it up. You're going to turn it to the right, and that's going to allow the flow of gas, and you're going to see that flow of gas represented by these numbers on your flow meter, and the numbers represent liters of oxygen per minute that you are causing the flow rate to come out at. So oxygen is ordered sometimes in liters per minute, or sometimes it's ordered in a percentage or fraction of inspired oxygen. So you'll see the abbreviation FiO2. And liters per minute can be calculated into how much FiO2 you're giving, or how much percentage, based on the device that you're using. So once, like I said, you get an order for oxygen, you've got the flow meter in the wall. You need to figure out what device you're going to put on the patient. You're going to connect that device to the flow meter. Now the flow meter has just a little threaded bottom where you're going to connect your oxygen tubing. Now some oxygen tubing is really skinny. And if you try and connect it to the flow meter at the bottom, it's not going to connect because it's too skinny. And you need an adapter. That adapter is this little green piece. It looks like a Christmas tree. It is called a Christmas tree. That little adapter gets screwed on to the bottom of your flow meter, just threads right on there. And then that allows you to connect tubing that may be too skinny to actually put on the bottom of the flow meter. Now, that's kind of old school, so if you're working in an old place and maybe they buy old tubing, you'll be using a Christmas tree. Back in the old days, you know, everybody would steal each other's Christmas trees and it was hard to find them, and you're constantly running around like, I need a Christmas tree, I need a Christmas tree. Nowadays, somebody got smart, and most of the tubing now, they actually made the base of the tubing fat enough to fit over the base of the flow meter. So it really depends on where you work, but you may hear the term Christmas tree, you may need that little adapter if your tubing doesn't fit. So I just wanted you to be aware of that. Okay, so in terms of oxygen, you know, again, like I said, how we're measuring it in either liters per minute or in percentage of oxygen. So think about how much percentage of oxygen do we breathe in the air, in room air. All right, so think about, go back to your high school days or your middle school days or whatever, when you learned about the percentages of gases in the atmosphere. And if you don't know it, you can go ahead and Google it and look it up, but I will give you the answer in a minute. But I want you to think about every day that we're breathing in room air, right? We're breathing in a certain percentage of FiO2, a certain percentage of oxygen. What is that percentage? Okay, so normal percentage of oxygen in the air is about 21%. So if I chart on a patient and I say the patient is on room air, I'm literally saying the patient is breathing in 21% oxygen. That's what we're all living off of. When a patient requires more than 21%, more than room air, then we're going to start putting them on devices. And those devices are going to equate into a percentage of oxygen. And I'm going to go over that as I talk about each individual device. Now, we have lots of different types of oxygen devices, nasal cannula, simple face mask, our non-rebreather mask, and you know, all the lists, all the ones that are on that list. I'm going to go over each one of them and explain again how much oxygen you're allowed to give, how much you're allowed to turn up the flow meter to, and what that equates into a percentage. But your job is to, of course, assess the patient's need for O2. You want to make sure that you know what their respiratory rate is, what their O2 sat is, what their lungs sound like, you know, what their work of breathing is. Are they using any accessory muscles? That's your job to figure out what's going on with the patient, and then, you know, start using your clinical judgment, thinking about maybe the underlying causes of why I might be escalating oxygen on a patient, and then of course choosing the right device. When you first start out, it's confusing. There's a lot of things to choose from. When you work in the hospital, I would always say respiratory therapy is a good friend to have. They're very patient usually. They will explain the devices if you've forgotten them or you're not really sure what to be doing. So when I first started in critical care, and we'd have patients who were intubated and on the ventilator, and then I would be, you know, getting orders to, you know, extubate the patient and put them on 35% humidified oxygen via face mask. And it may have been, you know, speaking a foreign language to me. I didn't know what they were talking about. And I'd go to respiratory and I'd say, hey, this is my first time extubating a patient. I really don't know how to do this setup. Can you show me? And they were always so good about helping out. So always use your resources that are available to you for specific departments. Oxygen devices are divided up into two different categories: low flow oxygen devices and high flow oxygen devices. And that doesn't necessarily just mean how high or low we're turning up the flow rate on the flow meter. It means how the oxygen is delivered to assist the patient with their work of breathing. So low flow devices are usually used as an adjunct for patients, but they're not necessarily in tremendous distress. They're going to have a mix of oxygen and room air that they're breathing in. We're not controlling their FiO2 as specifically, versus a high flow device that's going to be more specific to the patient. It's going to be more than their required needs. We have more control over the exact amount of FiO2 we want to be giving them, and those are usually for patients who are in more distress. And so you'll see like high flow device, low flow device, what does that mean? And if you look at, I think it's the next slide, sorry, 2 more slides. I have them divided up as to which devices are considered low flow devices and which devices are considered high flow devices. And again, I'm going to go over each one of these devices with you guys. So we're going to start with nasal cannula because that's really the most common device that you're going to put on a patient, right? So you have the patient's nasal cannula. There's 2 little prongs at the base of the cannula. Those 2 prongs go into the nose. How they go in is there's a little bit of a curve on the nasal prongs, and so you want to make sure that that curve is going into the nose directly. So you want to put the prongs inside the patient's nose, and then you're going to be wrapping the tubing around the patient's ears. So the prongs are in the nose, the tubing goes around the ear, and then there's a little slide clamp here. This slide clamp is what's going to go under their chin to lock it in place. So when you guys are going to be practicing today, you're going to be practicing putting the nasal cannula on the mannequin. Some of these mannequins' ears aren't that great, so yes, they do slide off a bit, but I still want you to practice and get the gist of it. So nasal prongs go in the nose, you wrap around the ears, you close the slide clamp, and then you must connect to the oxygen on the wall. Now, this is skinny tubing, so I'm going to need my Christmas tree to connect to that flow meter over there. Otherwise, it's not going to be able to go on the patient. So I'll do that in a minute. I'll show you how to connect. What you need to know about nasal cannula is if your patient requires nasal cannula, you can put the flow meter, you can set it anywhere from 1 liter to 6 liters per minute. That is the maximum you're allowed to turn the flow meter up. When you turn the flow meter on, there'll be a little silver ball inside. That little ball will rise up, and then you just want to have it stop on anywhere between 1 and 6 liters, depending on what the patient needs. Typically, the average order is always starting at 2 liters per minute, and then you're going to be able to increase or decrease accordingly. So what does that mean? So remember we talked about room air being 21%. Well, if I put my patient on 2 liters of oxygen, right, I'm giving them 28% FiO2, right? That's the percentage of oxygen they're getting that they're going to be breathing in through that nasal cannula. If I increase that flow rate on the flow meter up to, let's say, 3 to 5 liters per minute, then my patient's going to be getting anywhere from 32 to 40% FiO2. And if I max them out at 6 liters per minute, then the patient's getting approximately 44% FiO2. Now, if they're maxed out at 6 liters, and I know that they're at 44% FiO2, and they're still not doing well, and I need to go up on their oxygen, obviously I'm going to be needing to give them a device that's going to be able to provide more than 44% FiO2. The reason why you cannot go over 6 liters per minute on the flow meter is because that flow rate going into the nose is extremely drying and irritating, and anything more than 6 liters on a regular low flow device of nasal cannula is going to cause a lot of irritation to the patient, and obviously they're escalating in their need for FiO2, so we're going to have to raise it up. If I want to use something called high flow nasal cannula, okay, that is a high flow device. Now these devices were starting to be used before COVID, but they kind of came in handy during COVID because those patients were so hypoxemic, and they really were trying to avoid intubating these patients because they really weren't having an issue, right? They were having more of an oxygenation issue rather than a ventilation issue. So they were putting these patients on high flow nasal cannula if they could tolerate it. So a high flow nasal cannula is kind of like a regular nasal cannula, except there's a few things that are required. If you're going to be putting the flow rate on a high flow nasal cannula, let's say up to 10 to 15 liters per minute, this device specifically requires 2 things. It requires humidity and it requires heat. So when respiratory would come and set up the high flow nasal cannula on your patient, it comes with a warming element and a humidification element so that that patient's nasal mucosal membrane does not get completely dried out. If you have too much oxygen flowing and not humidity and not heat, the nasal mucosa is going to get really dry. Sometimes patients get nosebleeds, and some patients, even on high flow nasal cannula with the heat and the humidity, cannot tolerate that high flow rate, and sometimes you have to switch off to a different device. But if they can tolerate it, it could be really a nice bridge to get them over the hump and keep them from having to be intubated and put on a ventilator. So if I put my patient on high flow nasal cannula, as you can see, if I have them at 10 liters per minute on the flow meter, that's going to equate to approximately 65% FiO2, which is pretty high, right? And if I put them up to 15 liters, which is the maximum amount you can turn the flow meter up to, that's going to get them up to about 90% FiO2. And remember, 100% is the max, so that's really, really nice FiO2 to be able to give somebody if they can tolerate that 15-liter flow. Again, not every patient can. Now, another low flow device that I may be using on a patient is just something called a simple face mask, right? It's just a regular face mask that you put over the patient's nose and mouth that has a little bit of an aluminum strip that just kind of squeezes onto the nose itself. And then it has the tubing that's going to get connected to your flow meter at the wall. And again, how much I set my flow meter at the wall is going to determine how much FiO2 I'm going to be giving this patient. So typically, if I set my flow meter from anywhere from 5 to 8 liters per minute at the wall, and I put them on a simple face mask, then they're going to be getting anywhere between 40 and 60% FiO2, which is good. It's a nice way to increase the patient's oxygenation if the nasal cannula is not working. Now, there's another reason why I might put somebody on a simple face mask and they're oxygenating just fine. They're not having any issues with their oxygenation in terms of, any kind of underlying condition. But these are the patients who typically are our mouth breathers. So a lot of times I would get patients out of the operating room into recovery and the patient's still sleeping. These are the patients with a history of sleep apnea, or what we call obstructive sleep apnea. It's abbreviated OSA. And if those patients are targeted for obstructive sleep apnea, right, we're worried about their airway. We're worried about their breathing because of a mechanical issue, not because they're having more of a ventilatory issue. So we're going to put the face mask on the patient because they're a mouth breather. And if I put the nasal prongs in their nose, it's not going to do anything for them, right? So on those particular patients, I'll put a simple face mask on. I'll keep the oxygen flow at maybe 2 liters per minute. I don't need a lot of oxygen, but it's just a way to be able to get them their oxygen that they need through their mouth breathing versus through their nares, okay? So that's just another kind of secondary use for a simple face mask that you may have to consider. And a lot of patients do have obstructive sleep apnea. You can ask them. If they don't know, you can certainly ask their partner, do you snore? Do you kind of, gurgle or gag in your sleep? Does it wake you up? Do you snore hard or heavy, things like that, or stop breathing, every couple of seconds or whatever? Those are the people that we're targeting for sleep apnea, all right? So the next mask that we're gonna go over is something called a non-rebreather. Now the non-rebreather mask has 2 names. It's one mask with 2 jobs. So this is called a 100% non-rebreather mask, and it is also called a partial non-rebreather mask. And there's something on the mask itself that determines how you're going to use this mask. So if I have a patient who needs to be on 100% non-rebreather mask, right, that's going to be high flow oxygen. It's kind of like what you see in an airplane, right? They say if the mask drops down, put it on, the oxygen is flowing through the bag. Well, we are setting this up ourselves by putting the mask on the patient. And the mask looks like a simple face mask, but it has 2 little discs on either side of the face mask. These discs are very important because this is what's going to determine how it is either a partial non-rebreather or 100% non-rebreather. And then we're going to plug the oxygen tubing into our flow meter on the wall. And again, how high up we put the flow meter flow is going to determine how much FiO2 I'm going to give the patient. So if I need to put the patient on 100% non-rebreather, right, they're not doing well and they need 100% oxygen, I'm going to get this 100% non-rebreather. I'm going to plug it into the flow meter on the wall. I'm going to turn the flow meter all the way up to the top, up to 15 liters per minute. And then on the sides of the masks where those little openings are, there's a little flap. This is called a little disc flap, right? It's like a little rubber flap. And there's one on either side of the mask. So if my patient requires 100% non-rebreather, then that flap needs to be on both sides of the mask. Now, why? Here's why. When you're breathing out of this particular mask, the oxygen is flowing into the bag reservoir. There is 100% oxygen flowing into this reservoir. When I take a deep breath in through this mask, those little flaps are going to close over those little hole openings. When the flaps close over the openings, it is preventing me from breathing room air and mixing it with my 100% oxygen. So I am only breathing 100% oxygen when those flaps are on. So when you take a deep breath in, that is considered negative pressure, right? So it's causing the flaps to suck closed. Now when I exhale, that's considered positive pressure. So these little flaps are going to open up, and that's where my exhalation is going to go, out the flaps and out into room air. And then I'm going to take another deep breath, the flaps are going to close, and I'm only going to get the 100% oxygen out of this particular device, okay? Now, that's a high flow, 100% non-rebreather. If I want to do a partial non-rebreather, and I will do a couple of things. One, I can lower the flow meter down from 15 liters to, let's say, 8 to 12 liters. I can start taking a flap off one at a time. When I take the flap off, what's happening is the patient now, every time they take a deep breath, let's say I just take one flap off, I'm going to be breathing in room air with that 100% oxygen, and it's going to dilute it. And so it's not going to be 100% anymore. It's going to be a mix, right, of room air with the oxygen that's coming out of the reservoir. How much? It depends on what my flow rate is. So if I set the flow rate to, let's say, 8 to 11, I'm going to be using 50 to 75% FiO2. So I'm weaning down the patient's oxygen requirements. We don't want to keep a patient on 100% oxygen. That's not good. It means they're not doing well. So let's say the patient has fluid overload, right? They have congestive heart failure, and maybe they were starting to go into flash pulmonary edema, and they were starting to get really, a lot of fluid in the lungs, a lot of crackles, and we put them on 100% non-rebreather, and then we go ahead and give them some Lasix, right? Some furosemide, which we know is a loop diuretic. We're going to let them kind of pee off of that extra fluid, and they're going to start doing better, right? Their O2 sat's going to go up, the crackles are going to go down, the edema is going to go down, and the patient's going to start doing well. Well, let's start weaning them off that 100%. So to wean them off of the 100% non-rebreather, I don't need to go and get another mask or another device. I can just lower my flow meter rate at the wall, and I can start taking the flaps off and see how they do, okay? So it's an easy way to wean the patient slowly so you can see how they're doing, all right? So that is the 100% non-rebreather and the partial rebreather mask, 2 in 1. The next thing we have is a high flow device called a Venturi mask. The reason why this is a high flow device is because we can actually set the percentage of oxygen that we need. So if I'm putting a patient on this mask, I am setting my FiO2 right here on this little dial. So the dial tells me how much I should be turning the flow meter up at the wall. So it says to put it at 6 liters per minute. And then I just turn the little knob and choose which percentage of oxygen I want to give. So if I want to give 50% or 40% or 35%, I just turn the dial until my lines are lined up with the dial and with the percentage of oxygen. And then I set my flow meter on the wall to 6 liters per minute, and then I know I'm giving the patient that exact amount of oxygen. And again, I can wean the patient by just keep turning the oxygen requirements down. And the way that the oxygen is mixing with room air is down here at the actual little device that's allowing me to set the FiO2 percentage rate. So as I turn the oxygen down, it is starting to mix with more room air. If I need to turn the oxygen up, then I'm turning the disc and it's closing off to room air. And that's how the patient is getting that control right through the Venturi mask, okay? And we also have something that we can use for patients that can also control the percentage of oxygen we're giving. This is a humidified device, meaning that, let's say I want to put my patient on humidified oxygen. What does that mean? It just means I'm giving the patient sterile water, right, under compression, that's going to make their oxygen more moist and misty. so that their mucous membranes are less dry and they are able to tolerate maybe that face mask after they've just been extubated. And so I want to set the patient to that, let's say 35% or 40% FiO2 after they're extubated. So I would get something like that, looks like this. It's a long corrugated tubing. The tubing end will be connected to a face mask that will go over the patient's face, right? We can put a simple face mask on the patient and connect the corrugated tubing to that. And then the humidified bottle has a little, again, a little screw at the top, and that screw is what goes right into the flow meter. So all you have to do is screw it onto your flow meter at the wall, and then you're going to set your flow meter to whatever number you need to get that percentage of oxygen. So let's say I want to put the patient on 35% FiO2. I'm going to turn my flow meter up, and I'm going to go ahead and turn the dial on this humidification bottle to 35%. If I need more, I just turn the dial to 40% or 50%. I really like this device because it's very easy to control. If you're giving that much percentage of oxygen, typically you should have it humidified. It's just more of a comfort measure for the patient. It doesn't dry out their mucous membranes as much, and I find it keeps patients from, coughing or just from having laryngeal spasms and things like that. So it's always good to have them on humidified oxygen when you're at those higher percentages. Now, other devices that you might see that might be considered a high flow might be a nebulizer treatment, or again, if your patient is intubated and on a ventilator. Sometimes you see patients getting connected to albuterol, maybe they're wheezing, they're having a lot of trouble breathing, and you want to give them a little bronchodilator treatment. We use albuterol for that as a rescue med in the hospital. It's a liquid. We put it into the aerosol chamber, right? We squeeze the liquid in, and then we close the chamber. We have the patient, if they're able to, hold it and use the mouthpiece, they can use that. If not, I can also take off this piece and I can pop a simple face mask right onto the device, and the patient can have, I can just use a face mask if the patient's unable to hold the actual mouthpiece in their mouth. So I can do either one. Same thing, I have to connect the tubing to my flow meter at the wall, and then I have to go ahead and set my flow meter to be able to create that mist. Typically about 6 liters is enough, 6 liters per minute is enough to get that albuterol really misting, and then it looks like a big fog of mist and medication that the patient's going to be breathing in and out, in and out, in and out until it's finished. And those are really effective when the patient's having respiratory distress due to wheezing, and either it's an asthma attack or whatever may be happening with the patient. Sometimes you can also use these with a little bit of saline if you just need to give humidification only and no medication if the patient's really dry, as a comfort measure. Now, one of the other problems we have with our patients is, especially those patients that we're talking about who have obstructive sleep apnea. Well, those patients, especially when they come out of the operating room or after they get something like an opioid and they start to become sleepy again, they may start to obstruct their airway, right? The tongue falls in the back of the throat. You'll see, if the patient's on a monitor, you'll see the respiratory rate go flatline. You'll see the oxygen saturation plummet like a stone, and you're going to need to get those patients' airway secured, right? No amount of oxygen is going to fix this problem. It's a mechanical problem. We've got to get the tongue out of the way, and we need to put in an airway device. There are 2 types of airway devices. There's an oral pharyngeal and a nasopharyngeal airway device. They are usually stocked, certainly in critical care areas at the bedside. Otherwise, they're in your supply room. You need to figure out what's the right size for the patient. We have a kit here that has multiple different sizes, from pediatric all the way up to large adult. And the way you measure your airway device, if you're going to do an oral pharyngeal airway, is you need to put the one side of your airway at the tragus of the ear and the other side of the airway at the side of the lip. And that's how you're going to measure if it's the right size for the patient. So if it's too small, you need to go up a size. If it's too big, you need to go down a size. When you're putting in an oral pharyngeal airway, you'll see that the airway is curved, right? It's curved like the tongue. However, there's a little trick to putting in the airway that you need to know about, because you may end up having to put one in. Even if you're working on a regular floor, you may have a patient who comes back from the OR, they seem wide awake, they're in a lot of pain. You go to give them some pain medication, and then within 5 minutes, all of a sudden they're obstructing their airway, and you've got to go ahead and put an oral airway or a nasal pharyngeal airway in place. So the two things that you need for the airway, obviously, is the airway itself. So you need to be able to measure quickly and know what the right size airway is for your patient, and you need a tongue blade. And what you want to do is you want to grab the tongue blade, you want to find the patient's tongue. Ooh, my tongue blade just broke. You want to hold the tongue down, and when you're putting in the oral airway, you're not putting it in with the curve down, you're actually putting it in with the curve facing up towards the ceiling. So you're going to put it in straight with the curve facing up towards the hard palate. As you advance the airway, you are going to rotate 180 degrees and get that airway back upside down and over the tongue correctly, all right? So once again, when you're putting in the airway, you want to have the tongue blade holding the tongue down. You want to have the curve of the airway facing the ceiling. You're going to put that up towards the hard palate. You're going to advance it into the airway. As you advance it, you're going to rotate it 180 degrees. That's going to get it over the back of the tongue, and that's going to curve that tongue down, and it's going to open up your airway. Now, once your airway is in place, that means your obstruction is fixed, but you still need to make sure now that the patient's actually moving air. So you want to look for chest rise and fall. You also want to put the patient on an oxygen device, and since they're breathing out of their mouth now, what device do you think we're going to need? Okay, we're going to need that simple face mask. We're going to put the face mask now over the patient's nose and mouth, and we're going to watch for what is going to make me happy that I'm going to see in my mask, right? So if I know the patient's chest is rising and falling, I should see steam or mist in the mask, right? That exhalation, that condensation. And I'm going to know the patient's moving their air, they're getting their airway is open, they're breathing, and the next thing I need to do is plug my oxygen into the flow meter at the wall and turn the oxygen on so the patient's getting the oxygen that they require. And they probably don't require a lot of oxygen because this was just a mechanical obstruction and not a problem with them oxygenating, okay? So again, there's lots of different reasons why patients need oxygen. It's up to us to kind of sleuth it out and figure out what they need. Now, the other form of airway that we may need for the patient is a nasal pharyngeal airway. So sometimes you have a hard time getting an oral airway in because the patient may still be a little bit under the effects of anesthesia. They may be clamping down at the same time that their tongue is falling in the back of their throat. So you may need to put a nasal airway in. And sometimes patients come out of the operating room with a nasal airway. Sometimes they come out with both a nasal and an oral airway, especially if anesthesia is really concerned about the patient's airway. Those are typically your patients with big necks, right? You see these bull necks on these patients. Anesthesia does not like those necks. They are typically the patients who have obstructive sleep apnea, and they're typically the patients who may obstruct postoperatively. So sometimes they come out in advance already with an airway in place, and sometimes two. Now, with the nasal pharyngeal airway, the way you measure it is you go from the tragus to the nares, right? That's how you're going to measure the right size for the nose. And then you're going to get a lubricant. Because we're going into the nose, right? We don't want to cause trauma to the patient. So you need to make sure you have a lubricant that you're going to put on the nasal airway. And then this one you don't have to turn in any way, shape, or form. It's got the curve. You want to go into one side of the nares, and you just want to advance that airway on whichever side you meet the least resistance, because everybody has somewhat of a slight deviation, right, inside the nose. The septum's a little deviated, and there's always one side that's a little bit easier to drop the airway into. So you have to determine, if you're putting it on one side and you're meeting a lot of resistance, do not try and force it. Go to the other side, add a little bit more lubricant, and then go ahead, and it should pretty much gently go into the nares. Again, once that's in, you want to go ahead and put your simple face mask over the patient, because you need to give them that oxygen via face mask, and you're looking for the same thing. You're looking for chest rise and fall. You're looking for mist in the mask, and you're looking for that O2 set to come up on your O2 set monitor, and that patient is no longer, struggling to breathe, to get air movement, and the O2 set slowly comes up, all right? And that's gonna be putting in a nasal pharyngeal airway. So I'm just gonna show you those slides, which you can kind of scroll through in your, along with me as well. Now, one thing I just want to show you, I'm going to walk around the bed because I talked about how we're going to get the oxygen onto the wall, right? So on this wall unit, I already have my flow meter connected to the wall. I'm going to take my Christmas tree because all of my tubing is pretty small, and I need to put the Christmas tree adapter on there so I can connect the tubing. And then I want to take my patient's oxygen tubing, and I'm going to go ahead and plug it into the Christmas tree, and then I'm going to go ahead and turn on my flow meter. Hold on, my compressor, I just have to turn the compressor on. The compressors are loud, so I typically don't have them on when I'm teaching, but when you guys do your practice, you'll have the compressor on, and then when you go to turn off the flow meter, you'll actually see that the silver ball will rise and fall, and you will be able to set your flow rate at whatever you want to practice with. So again, this gentleman's on a face mask, so I can do 5 to 8 liters if I need to, and I'm just going to go ahead and watch that silver ball sitting at that 8-liter mark here, okay? But for now, I'm going to turn it off because, again, it's a little loud when I'm teaching. Okay, and you guys will get to practice that. The other thing I want to show you is suction, because suction goes hand in hand with airway and with oxygen, and sometimes patients are having trouble breathing, trouble controlling their airway. They're also having trouble controlling their secretions. So we do a lot of suctioning on patients in those situations, and there's lots of different ways to suction a patient. For you guys today, I'm just going to show you how to set up the suction machine and the tubing and the device and the canister, and then how to just do simple oral suctioning. When you guys go into, I think it's pediatric rotation, you'll be doing sterile suctioning, and we're going to talk about sterile technique in the next video. But when you're doing sterile suctioning, that's typically on your patients who have a tracheostomy or an endotracheal tube, and the tubing and the procedure needs to be sterile. But when you're just suctioning out the mouth area, it does not need to be sterile. So when you're setting up your suction, you need a couple of things. And the way it's packaged in the supply room is there's a suction canister, right? It's a canister that has the graduated markings in mLs, because if you're sucking stuff out of a patient, sometimes you may need to be capturing that amount. But if you're just doing regular suctioning, again, just like mucus and stuff, you're not going to be measuring it. And then you also have 2 sets of tubing, a short tubing and a long tubing. All right, the short tubing is what goes from the suction wall unit on the wall onto your suction canister. Now, what's very important about your suction canister is you need to, one, make sure that the top is on very secure. It has to be completely snapped on. If there are any leaks in the canister, you are going to lose suction. So the first thing you do is put the lid on and make sure that's tight. And then on the top of the lid are a bunch of different openings, and they are telling you, one says patient, one says vacuum, one says ortho, and then the big one is the drain opening. So you want to have the drain opening closed. The ortho line, to be honest with you, typically we rarely ever use that, so you're going to have that one sealed up. And then the vacuum line and the patient line are going to be the 2 lines that you're going to connect your tubing to. So the first line, the vacuum line, is the short line. And the reason why it's short is because it's literally just going from your suction flow meter to the vacuum line on your canister. And the canister will sit right at the head, on the head wall in a little holder. Your long tubing, that's the tubing that's going to go in the part labeled patient. So that's going on the patient's side, and we need a lot of slack on that, right, to be able to get to our patient. So if I'm suctioning my patient and I'm just suctioning their oral airway, let's say they're having a hard time, they're pulling secretions or they can't spit out their saliva yet, I'm going to go ahead and help them with suctioning. What I'm going to be using is this suction catheter. It's called a Yankauer catheter. It's kind of like what you get at the dentist office, right? The thing that they put in your mouth. It gets connected to your suction tubing. It's just hard plastic. It doesn't go anywhere but just the oral pharynx. And if I need to suction my patient's mouth, I'll be able to just put this in and around the mouth, just like what you get at the dentist. Now, when I look at my suction meter up here, it's got a couple of different settings that I have to know what to set it to.